So hi everybody, my name is Khadijah. I'm a CT2 in Pilgrim. So I'm going to be talking to you about cardiovascular reflexes and then a little bit about the Valsalva maneuver as well. I've been told it's a hot topic for the Viva. Hopefully this will be a concise explanation. Feel free to correct me wherever I'm wrong. So just about what is going to control your blood pressure. So the different mechanisms that are already set in the body that keep a very tight control of our blood pressure. So you have autonomic center, which is basically via the vasomotor center, and then you have your baroreceptors. You have humoral control, which is via catecholamines, the RAS system, and vasoactive substances as well. And then you have your renal system, which in itself also controls your blood pressure apart from the RAS system. So we're just going to be touching on all of these a little bit as we go through the presentation. So just a little bit about what will influence it. So we know that the cardiac output and systemic vascular resistance influence your blood pressure, and the cardiac output in turn is influenced by your heart rate and stroke volume. And for that, we need to know your preload, contractility, and afterload. So any of these things in this table, if they go off balance, they will have a direct effect on your blood pressure. And at the end of the day, our reflexes, our cardiac reflexes are more or less there to help to maintain it within normal physiological level. So autonomic control is the most rapid response in the body. And our blood vessels receive sympathetic innervation, including the capacitance vessels. And the arterioles are the most densely innervated. So autonomic control is via the noradrenergic hormones, and the effects are vasoconstriction at the vessel ends, chronotropy, inotropy, and suppression of the vagal tone as well. So this is how it more or less works and influences. This is just a repetition of the first table that we saw, but it was a little bit more colorful. So vasomotor control is controlled by the medulla, and which is influenced by the discharge that you get from your sympathetic nerves. And the sympathetic nerves are in turn influenced by systemic vascular resistance, your stroke volume, heart rate, and the contractility of the heart. And the factors that affect this activity are direct stimulation, which is by carbon dioxide and hypoxia, excitatory input, which is from your cortex, your pain pathways, the carotid and aortic chemoreceptors, and also inhibitory pathways, also from the cortex, and in addition to that, the lungs, the carotid, aortic, and the cardiopulmonary baroreceptors. And then you have chemoreceptors, which are also in your aortic and carotid bodies, and they respond to hypoxic and hyperbaric stimuli, and in turn increase the blood pressure. Your baroreceptors, so you have two groups. So they're located in your carotid sinus and in your aortic arch. And then you have cardiopulmonary receptors, which are in the right atrium, the left atrium, the inferior vena cava, the superior vena cava, and in the pulmonary veins. So the receptors basically respond to a sustained pressure and carry signals via the glossopharyngeal nerve. And I basically think of it this way, that they're at physiological blood pressure, they're always firing, and then they really kick into play and get confused once the blood pressure drops. And once that blood pressure drops, they go and stimulate the sympathetic nervous system, and then carry out through this pathway, stimulate the sympathetic nervous system, and then cause all the noradrenergic effects that we spoke about in the previous slide. So everybody happy with autonomic? Moving on to humoral mechanism. So catecholamines, we spoke about them. So that's your adrenaline and NORAD release, which is by the medulla, adrenal medulla, and that causes sympathetic stimulation. And then you have your endothelium, which releases a number of different things. So, and everything has its own effect in regulation for blood pressure. So you have thromboxane A2, which causes vasoconstriction and platelet aggregation. You have prostacyclins, which inhibit platelet aggregation and also cause vasodilation. You have nitric oxide, which causes vasodilation. You have adenosine, bradykinin, and histamine, which cause vasodilation, and you have endothelins, which are vasoconstrictors, and these are all released from the wall of the endothelium. So a little bit about the renin-angiotensin-aldosterone system. Everybody's familiar with it, and it kickstarts from the kidney. So when you have a drop in blood pressure, the juxtaglomerular complex picks it up and causes release of renin from the kidneys, which goes and converts your angiotensinogen, which is produced from the liver, into angiotensin 1, which then goes to the lungs and is converted by ACE into angiotensin 2, and then the angiotensin 2 is what is your vasoconstrictor and goes and acts on the blood vessels. In turn, it also goes and acts on the adrenal gland and causes release of aldosterone, and aldosterone goes and acts on the kidneys to stimulate reabsorption of sodium, and in turn, because of that, we reabsorb water as well. So it's actually a very tightly controlled system, and this reflex also keeps our blood pressure in control. This is just another explanation of the same. So renal control, vasopressin is released, which is ADH, which goes and acts on the collecting ducts released by the pituitary gland. Sodium retention also increases the circulatory volume. We spoke about the RAS system. In addition to this, the kidney also exerts control by erythropoietin synthesis, but this is more long-term control rather than short-term reflexes. And of course, your ANP and BNP also cause natriuresis as well. So just the Valsalva maneuver. So we are expected to know how to draw this graph very quickly in 5 minutes and explain it. I'll be going through the phases of it one by one as we go along. It's your blood pressure at the top bit and your heart rate at the bottom bit, and we just see in each phase what the difference is between the two. Valsalva is just in simple terms, blowing out against a closed glottis. And when we do that, it increases our intrathoracic pressure. In this graph, at the 10-second mark, they started at 40 centimeter of water intrathoracic pressure applied, and it will kickstart this reflex. So for what happened in phase 1, because you are increasing your thoracoabdominal pressure, what it does is it suddenly increases your venous return, and because there's increased blood going up into the heart, there's a reflexive increase in blood pressure, and because of that increase in blood pressure, our heart rate comes down. While you sustain that pressure, you enter into phase 2. The sustained pressure reduces the venous return and rapidly causes the blood pressure to fall. And because of that fall in blood pressure, we have reflexive tachycardia. An MC question is, in autonomic neuropathy, you just have excessive fall in the blood pressure. And it's a test, is one of the tests to see if there is any autonomic neuropathy. Then you enter phase 3, is where you release the pressure. When you release the pressure, because you have this large reservoir, which is empty, and it causes the blood pressure to plummet even further. And with that, because the blood pressure has fallen, the heart rate continues to rise and remains elevated. And then you have phase 4, which is the last bit. So because your heart rate has been raised, has been slowly going up initially, it causes raised blood pressure, and as the venous return comes back, it causes reflexive bradycardia and then turns back to normal. And in autonomic neuropathy, another test is your blood pressure does not overshoot. So in phase 2, it falls down a lot, and in phase 4, it doesn't have as big as an overshoot as it would in somebody whose autonomic system is intact, and also there won't be any reflex bradycardia as well. This is my references from e-learning and from Chambers. Any questions?
Okay, I've got nothing on the chat as far as questions. So are there any people that want to unmute themselves to ask anything specific?
Or anything?
Okay, everyone's very quiet. I think one of the things I would definitely take out of that lecture, and although it's slightly more pharmacology than physiology, is the roles of all the different catecholamines, particularly sort of why endogenous noradrenaline and adrenaline have the effects they do versus some of the effects we see when we give exogenous, so the drugs we give in ITU. So one of the things that the examiners like to ask you about is what the different roles of the catecholamines are. So I hope you've all got that in your pharmacology banks. Anyone got any other questions? Nothing so far. Okay, thanks, Khadijah.
No problem.
Who would like to? Who's taking the floor next, as it were?
I think I'm next. Sorry, I'm just going to try and share the. So we're going on to the pharmacology of inotropes and vasopressors. Okay, so just as you mentioned it. Okay, let's see. Sorry, I'm just going to figure out how to desktop. Okay, can everyone see the presentation?
Can indeed. Okay.
Okay, so hi, I'm Jade. I'm one of the CT1s that's currently at Kettering General Hospital, and I'm just going to be doing a presentation on the pharmacology of inotropes and vasopressors. So basically the objectives for the session is to relate the mechanisms of action of our inotropes and vasopressors to normal cardiovascular physiology. So just briefly on that, and then explain how we use those inotropes and vasopressors in terms of like how we can modify our modify the physiology using those as pharmacological agents. So just briefly on the physiology, I think we mentioned in the last presentation as well. So we use inotropes and vasopressors to affect our mean arterial pressure. That in turn is controlled by our cardiac output and our systemic vascular resistance. So cardiac output is then affected by or made up of, I suppose, your stroke volume, which is controlled by your preload, your myocardial contractility, and your afterload. And then your cardiac output is directly proportional to your stroke volume as well as your heart rate. So the things that we therefore try to target is the heart rate itself, the myocardial contractility, as well as the systemic vascular resistance. So broadly, inotropes increase your myocardial contractility, and then vasopressors will cause your peripheral arterial vasoconstriction. As we can see in the formula, I suppose, for mean arterial pressure, they both directly proportional. The cardiac output and SVR are both directly proportional to your mean arterial pressure. So by increasing either one of those, you should get an increase in your mean arterial pressure. So looking at the specific adrenergic receptors that we target, our beta-1 receptors control inotropy as well as chronotropy. Sorry, this wasn't this edited version, so it's inotropy and chronotropy. Beta-2 is got also weak inotropic effects, but mostly vasodilation of your splanchnic and skeletal muscle beds. And then your alpha-1 is within your smooth muscle of your peripheral vasculature. And then activation of that causes peripheral vasoconstriction. One of the common MCQ questions I came across with was which of the receptors are G protein coupled, and all of these, as well as ones that we're going to mention a bit later, they're all G protein coupled receptors. Okay, so looking specifically at inotropes. So inotropes as a whole, they all basically act and have basically the final common pathway is that they want to increase your intracellular calcium. So by doing that, you increasing your contractility of the heart, and then increasing the force of myocardial contraction. So there's 3 broad categories divided into. So it's your sympathomimetics, which is your beta 1 and beta 2 adrenergic receptor stimulation, so direct stimulation of those receptors, your phosphodiesterase inhibitors, and then there's other mechanisms as well. So specifically, just to show for those of you that are a little bit more visual, so if you want to just look, if you can see the picture of your, like the cell membrane, you can see the red squiggly thing is your beta adrenergic receptor, and then you've got your G protein coupled receptor as well. So basically what happens is when that receptor is stimulated, it causes your G protein receptor to dissociate, and then binds with your adenylate cyclase, which then basically forms your cyclic AMP, and then your cyclic AMP causes an influx of calcium into your myocytes, and hence increasing your heart rate. So one of the things that's not on this picture, but just to be mindful of for something that we'll mention later in the presentation, is that phosphodiesterase then causes your degradation of your cyclic AMP once this whole process has occurred. So, so looking at your sympathomimetics, so these are the drugs that we use to directly stimulate our adrenergic receptors. So these come up really commonly in your multiple choice questions, and like specifically which drugs affect which receptors. And I've also seen a couple of questions as to which what receptors they affect at low doses, and then what receptors they affect at high doses. So that's why I've just made a note of that, just because I've seen it quite commonly. So specifically looking at adrenaline, so we know adrenaline basically can affect your alpha-1, beta-1 and beta-2 receptors. At low doses, it's more active on your beta-1 receptors, and then as you increase your doses, it becomes more, I suppose, active at your alpha-1 receptors. So basically, because then it has an effect on your alpha-1 receptors, because it affects your beta-2 receptors, it can cause a fall in blood pressure, because there could be peripheral vasodilation. So even though your cardiac output is maintained because of the chronotropy and inotropy, your blood pressure, you might see a bit of a drop in the blood pressure. And then, so also we're cautious with using adrenaline, we're a bit more cautious with using adrenaline in like as infusions, like in ITU, because this could be associated with lactate production, which can worsen acidosis for patients that are already septically ill and trying to avoid that acidosis with them. Then next we have dopamine. So dopamine basically has got, at low doses, affect your beta-1 receptors, and then as you increase your to higher doses, it increases the action on the alpha-1 receptors. So also, it causes nausea and vomiting because it can also affect, well, it also stimulates D2 receptors. And then, so that's also just a side effect of using that. And then peripheral dopamine 1 receptor activation can cause vasodilation of your renal and mesenteric beds as well. And then it can also cause a tachycardia at high doses, and that's particularly in patients with an inadequate preload. So patients that are basically but fluid deplete or haven't been adequately resuscitated fluid-wise. We just need to be careful with those kinds of patients with using dopamine. Then the next agent is dobutamine. So it mainly stimulates your beta-1 receptors, and with mild alpha-1 receptor action as well. It's structurally similar to the next drug, which I'm going to speak about, which is isoprenaline, but basically it causes less tachycardia than isoprenaline itself, for the kind of same amount of inotropy that they'll both cause. And then isoprenaline, it's more of a potent beta-1 and beta-2 receptor agonist, so it increases cardiac output, but then it also decreases your systemic vascular resistance, and that's as a result of your B2 receptors. So And those in IT are mostly used to treat bradycardias because of its potent beta-1 action. Then dopexamine is both a beta-2 and a D1. It's got actions on beta-2 and D1 receptors, and it causes inotropy via cardiac beta-2 receptors. As we mentioned earlier, beta-2 receptors got mild inotropic effects, and then the advantage of dopexamine is just that it's got a longer half-life than the other all the other agents mentioned. So adrenaline, dopamine, dobutamine, and isoprenaline have got half-lives generally between 3 to 5 minutes, and then dopexamine is just a little bit longer than that. So those are all the sympathomimetics. As I mentioned earlier, we also, one of the parts of the pathway that we target as well is phosphodiesterase. So we mentioned earlier that phosphodiesterase causes the breakdown of cyclic AMP, and then that would then reduce the amount of calcium, and then that reduce the amount of inotropic effect that we would want. So the point of we want to kind of inhibit that effect of phosphodiesterase, thus preventing the breakdown of cyclic AMP and still allowing that increase in calcium. So there's all different types of, I think it's 1 to 5 types of isoenzymes that have, phosphodiesterase isoenzymes, but the main ones are type 3 and 4, which have been identified as working in the myocardium itself. So if we inhibit these, we can create positive inotropy by, like I said, increasing your cyclic AMP and thus increasing your calcium level. So common agents that we might have heard of is enoxabolone and milrinone, and sometimes these can also be referred to as inodilators, as they cause peripheral vasodilation, and then you often need a vasopressor in addition to these just to maintain your blood pressure as well. And then aminophylline is also a non-selective phosphodiesterase inhibitor, which we have commonly used with things like asthma as well, but that also has some positive inotropic actions, which you might be seeing in patients as well. Okay, and then the other kind of class, which is, these drugs are also mentioned, but they just affect, a little bit more different effects in the pathway. So levosimendan increases your myocyte sensitivity to calcium itself by binding to troponin C, and if you get better binding of calcium, it also can increase your inotropy as well. Then digoxin, as we know, it's used as an antiarrhythmic, but can also help with inotropic effects because it inhibits your sodium-potassium ATPase pump. It increases your intracellular sodium within the myocyte itself, and then it decreases the inwards movement of sodium via the sodium-calcium exchanger pump, and so it reduces the movement of calcium outside the cells. And then we can use intravenous calcium itself, which transiently improves cardiac output, but the effect is quite short-lived. So that's more, I suppose, of just making sure that all your electrolytes are corrected. And then thyroxine, which is also positively inotropic and chronotropic. The method for this is, kind of a bit more not as well established, but they say it's probably via an intracellular calcium ATPase pump. So again, increasing your amount of calcium inside the cell and thus increasing your inotropy. Okay, so then moving on to vasopressors. So this, as we said at the beginning, our vasopressors can be used to treat low blood pressure, that's due to reduced systemic vascular resistance. And then obviously we want to increase peripheral vasoconstriction to increase systemic vascular resistance and thus increase our cardiac output. So the two broad I suppose groups is your alpha-1 adrenergic receptor activation and the second group is stimulating vasopressin receptors. So our adrenergic agents, so kind of just did this table the same as I did the sympathomimetics. So specifically looking at noradrenaline, so the receptors that affects is alpha-1, and it also has some beta-1 action too. So it's got minor inotropic action, which is also offset by a baroreceptor reflex, which we experience. So basically it has the as we mentioned earlier, the baroreceptor reflex has a vagal response to the increase in blood pressure. That's, yeah, like we were saying, that it will increase your heart rate as well, but not to the same extent that it causes vasoconstriction. Then ephedrine is also a mixed alpha and beta adrenergic stimulation. It works both directly and indirectly by directly stimulating those receptors, and it also displaces noradrenaline from storage granules as well. So it increases our endogenous secretion of noradrenaline. But this drug, as we've seen when we use it in theatre, can sometimes cause tachyphylaxis, as once those noradrenaline stores are then depleted, it has a lesser effect than it would have the first time you used it. Phenylephrine is a potent alpha-1 agonist, and then, like I said, it can cause a reflex bradycardia. And then metaraminol's got mainly alpha-1 with some beta action, and it has direct and indirect actions. So direct, as I said, mainly stimulating the alpha-1 receptor itself, and then it also has it also causes noradrenaline, endogenous noradrenaline release. So that's the indirect action, and then also increases pulmonary vascular resistance, so increasing your preload to the heart as well. So then vasopressin, so it's also known as antidiuretic hormones, ADH, or arginine vasopressin, or ABP. So there are various receptors throughout the body. So you'll see it's V1, like there's V1, V2, and V3. The ones that we target in terms of the effects for blood pressure are V1 receptors, as these are also G protein coupled receptors, as I mentioned before, as are the alpha-1, beta-1, and beta-2 receptors are as well. And stimulation of these vasopressin receptors causes peripheral vasoconstriction. So that was a very brief kind of summary of these. I think when using these pharmacological agent, we have to obviously assess the patient clinically to determine whether cardiac output or vascular resistance or both need correction. And then knowledge of the receptors and which drugs affect which receptors can then determine the appropriate inotrope or vasoconstrictor that we need to use. Thank you. Yeah, so all of this content is from e-learning for health. Yeah, so cool. If there's any questions, I can attempt to answer them.
Okay, thank you, Jade. That's another excellent presentation. Well done. I'm sorry, I just switched my video off. I'll turn it back on for a second. Fantastic. So are there any questions from the group? If there are, if you want to unmute yourself and ask now. Okay, not so many. So one of the things I'd like you to have a little bit of a think about is, why do we need so many different inotropes? Why over the years have we managed to end up with dobutamine, dopexamine, isoprenaline? Has anyone got any thoughts on that? Is there anyone that could answer that question for us?
I think probably there's been a lot of research or monitoring of patients where certain negative complications have been seen with some of these drugs. Reading some of I can't remember which drug specifically, but there was a PROMISE study, I think, at one point that was done that negated the use of one of the inotropes. But besides for finding negative complications of them, I'm not too sure what else.
Yeah, I think you've hit on the main point there, which is that none of them are ideal. Some are more ideal in certain situations. So, for example, adrenaline is extremely useful where there's been a huge amount of histamine release in anaphylaxis. But as you've described earlier, rapidly leads to lactic acidosis. Noradrenaline tends to be our sort of go-to support, which is actually not an inotrope. As you pointed out, it is in fact a vasoconstrictor. But there are some reasons why you might use some of the other drugs. One of the concepts I've always struggled with is what I call inotrope soup, and you see this a lot on cardiac intensive care units where people return from theatre on noradrenaline, adrenaline, dopamine, isoprenaline, sometimes digoxin, and you wonder what on earth is going on. And I think in those scenarios, if you were asked about what you would do and when you would use each specific inotrope, I think the only correct answer in the modern time is you get someone capable of doing a TOE, transesophageal echo, to work out what the heart is actually doing and where you're lacking your system. And if actually the heart is appearing to contract well and you've got high load, you don't need an inotrope. What you need is increased resistance. And if it's the other way around and you've got poor contractility but you've got high load, then what you need is something more inotropic, in which case things like enoxamone and milrimone might be a better option. So one of the things I was just thinking about is, why do we bother with things like isoprenaline at all? And the answer to that is quite simply, you can give it IV, not in ITU. So the majority of these drugs we've talked about, all the catecholamines, are all really expected to be given by dedicated central access. And one of the few drugs you can give out on a ward when you're trying to, save a patient or trip to ITU is isoprenaline. So that's probably its single reason to exist these days. Any other thoughts or questions on that before we move on? Okay, I'm taking that as a no then. Please be aware, I have seen multiple exam questions that involve you drawing the synthesis, which off the top of my head involves tyrosine kinase and some other things about how you make adrenaline and noradrenaline. I'm not going to bore you with that now, and I can't remember it off the top of my head, but it is something to make sure you've got a degree of fluency with. Thank you very much for that presentation, Jade. Who is next?
So I think I just have a quiz next, which I've made quite generally about cardiology pharmacology. So I'll just get that up.
Okay, take the screen.
So I'm Katie. I'm one of the CT2s working at Leicester General Hospital. That working? Can everyone see the presentation?
Yep.
Cool.
Yep.
So I just have, I think, 11 multiple choice questions. The first few are SBAs and then a couple multiple true false at the end. So I don't know, I haven't made it to the MCQ part of the last ones because I've been on call. But shall I just pause for everyone to think about the answer and then go to the next slide with the answer? Yeah, I'll do that. Okay.
Yeah, that could be an idea. Or you could get people to kind of, if you want people to shout out the answers as well, that's another option. But
oh yeah, that'd be good if people.
You can commit by using the comments at the side. So
yeah,
I prefer it if people commit to an answer like you would in real life, rather than sit on the fence about it. It just teaches you what you do and you don't know.
Yeah, it's a good idea.
okay, good idea. Yeah, everyone use the chat.
Okay, so the first question, a 47-year-old woman is admitted to intensive care. She's taken a propranolol overdose and was found to be hypotensive and bradycardic. Her observations in the emergency department show a blood pressure of 70/40, heart rate of 34. After treatments with fluids, her blood pressure doesn't improve and she remains bradycardic. Which one of the following is most likely to improve her hemodynamics? So if everyone can we see how many people we have? 1, 2, 3. Okay, we need at least 10 answers. Okay, perfect. So I think we're getting there. Ooh, where's the next one? Yeah, so the answer is E. You give glucagon. So I've put a bit more of an explanation there, but everyone's gotten it. So I feel like we can probably move on to the next one unless anyone has any questions. Dr. Ling, I feel like you should answer last though, because everyone's just going to copy your answer. So next question. So which one of the following patient groups is most suited for primary therapy with hydrochlorothiazide as an antihypertensive agent? So I know we didn't really go over hypertension and stuff, but I just thought I'd include some general cardiology as well. So patients with gout, patients with hyperlipidemia, young hypertensive patients with rapid resting heart rates, African Caribbean patients and elderly patients, or people with impaired renal function. Okay, so the correct answer is D. Yeah. So African Caribbean and elderly patients are better treated with diuretics than beta blockers or ACE inhibitors. The hyperuricemia that you get with thiazides can actually precipitate gout in patients. So people with gout don't tend to get them. You can also get LDL hypercholesterolemia that can increase risks of complications in hyperlipidemic patients. So that one was wrong as well. Anyone with young who has a rapid resting heart rate would benefit a lot more from beta blocker. And in renal failure, the way that thiazides work is that they can't really increase sodium output in a failing kidney, unlike giving increasing doses of furosemide, which we often see in renal failure patients. Okay, next question. So a 55-year-old man is admitted to ITU with community-acquired pneumonia. Over the next 24 hours, he becomes septic, needing hemodynamic support. Past medical history includes non-insulin dependent diabetes, ischemic heart disease. So inotropes that target adrenergic receptors were chosen to provide hemodynamic support. Adrenergic receptors are also found in non-vascular tissue. Which ones of the following would be appropriate response to stimulating the stated adrenergic receptor? I didn't do that, sorry. So anyone who didn't see the answer that I just showed could answer. Yeah, sorry, we'll move on. So it's just interesting to note what other effects these drugs have. Beta-1 receptors promote renin secretion. Alpha-1 receptors relax intestinal smooth muscle. And pancreatic alpha-1 receptors inhibit pancreatic hormones like insulin and glucagon. Cool. Be careful with my clicking. So a 5-month-old comes to A&E with decreased oral intake, fever, and irritability. ECG shows a rate of 220 beats per minute with narrow QRS complexes and no P waves. He has palpable femoral pulses and a respiratory rate of 50. Which one of the following is most appropriate initial step in management? just wait for a few more answers and we'll go. Yeah, so there's general consensus there. So giving adenosine wouldn't be wrong in this case if they already had a cannula, but a 5-month-old who's really irritable already with an SVT, as it's described in the question, the best initial step would definitely be to do do vagal maneuvers, and obviously with a less compliant patient, the putting a cold bag over their face for up to 5 seconds, not longer than that, to avoid any prolonged apneic periods, would help stimulate the vagal pathway. Okay. So, question 5. A 69-year-old man with a history of asthma, diabetes, and hypertension has presented to the emergency department with an episode of syncope. He's complaining of dizziness, shortness of breath, and unable to remember his date of birth. He appears pale with cool peripheries. ECG shows a bradycardia of 32 with type 2 AV block. 500 micrograms of IV atropine was ineffective at improving his rate. What would be your next treatment? Okay, so the correct answer is to pace him. This is just because he's clearly unstable. So the fact that he's confused, very peripherally shut down, something needs to be done a bit quicker. Mobit's type 2 AV block is a risk factor for asystole as well. So pacing him will be the best route of action for him. If he was stable and his blood pressure was okay, then something like isoprenaline could work in that situation. Okay, next question. 73-year-old, 61 kilogram female patient is admitted to ICU following aspiration of gastric contents post-induction of anesthesia. She's hypoxic with a PaO2 of 6.1 on 100% oxygen. She's had fluid boluses, metaraminal boluses, and now a NORAD infusion. On cardiac output monitoring, you get the following data. So heart rate of 96, blood pressure of 68/46, cardiac output of 2.5 liters per minute, PCWP of 20 millimeters of mercury, and systemic vascular resistance of 1400. The one agent best to normalize this patient's hemodynamic variables would be so either NORAD, adrenaline, dobutamine, vasopressin, or levosimendan. We're getting a good mix. Okay, so the data showing that she's actually she's well filled, but still has a poor cardiac output. So this would be normalized if we give inodilator, as we were discussing in the last presentation. So dobutamine fits that, but levosimendan also kind of fits that category as well. But because she's so hypotensive, that's why I think the answer has gone more to dobutamine instead of that. Does that make sense? Anyone can unpause at any time to ask any questions, which I might have to refer to one of the consultants. Okay, I'll move on to the next one. Select one option that best describes the current use of sodium bicarb in Resuscitation Council guidelines. Oh, sorry, I've just seen that question. Thanks. Okay, so the answer, it's only if it follows toxicity from tricyclic antidepressants. So I think before 2010, there used to be a lot more use of sodium bicarb in arrest situations. But now it's only recommended following tricyclic antidepressant toxicity, or if it's complicated by hyperkalemia, we can also give it rather than hypokalemia, which I mentioned before. Okay. So this is multiple true false. So the following statements about selective phosphodiesterase inhibitors are true. So I didn't write A, B, C, D down the side, but okay, so I found C quite difficult as well because they do increase your heart rate. So D is true, tachycardia is common, but because it reduces systemic vascular resistance, the ventricular systolic wall tension is reduced, so ends up decreasing myocardial oxygen consumption. Bronchodilation does occur, but it's not to a significant degree, which is a bit mean to put in there. And It's isoenzyme family number 3 that results in positive inotropy. Hypotension is due to the reduced systemic vascular resistance and smooth muscle relaxation. So, the following physiological changes may be seen with when commencing NORAD infusion. So increased insulin secretion, coronary vasodilation, even with no change in perfusion pressure, renal blood flow will increase, meiosis, and pregnant uterine muscle relaxation. Okay, so the only one that was correct is B. So NORAD decreases insulin secretion and may result in hyperglycemia. It vasodilates the coronary arteries, but as myocardial work may increase the balance of myocardial oxygen consumption and delivery, may lead to ischemia on NORAD. You get myodrisis rather than meiosis, and the pregnant uterus would contract in response to a NORAD infusion. So the effect of NORAD on the kidneys would decrease renal blood flow if the perfusion pressure of the kidneys was held constant. And it doesn't have much impact on GFR. So the beloved Vaughan-Williams classification. So basically, which one of these is paired up correctly? Which ones of these are paired up correctly?
you want to give us the answers? Put us out of our misery.
I'll see if anyone else would commit. But yeah, so all of them are false except for flecainide. But it's a bit of an annoying question because you have to remember the class and what each class does. Sotalol is named terribly because it's a potassium channel blocker, but it sounds like it would be a beta blocker. And I think that was most of the ones that people struggled with. And quinidine we don't use very often. But. Okay. So quinidine is a 1A, which prolongs the action potential. Lidocaine and phenytoin are class 1B, and they shorten. So those ones are kind of just switched around. Flecainide was obviously correct. And verapamil and diltiazem block calcium channels. Okay. So I think this is the last question, nearly there. So esmolol is useful in the treatment of essential hypertension, has a half-life of 2 minutes, largely excreted unchanged in the urine, acts selectively on beta-1 receptors, and possesses intrinsic sympathomimetic activity. Okay, so they're all false. It's obviously not useful in essential hypertension since we only give it IV and it has a short half-life, but it's not, the half-life is 10 minutes rather than being as short as 2 minutes. It's rapidly metabolized by red cell esterases, which I guess makes the 10-minute half-life make sense. And it's a non-selective beta blocker. Yeah, so that's all my questions. Does anyone have any questions or comments on anything?
No further questions, anyone? So I'd just like to say thank you to everybody who's prepared anything for today. Things I've learned today, that you guys are excellent presenters in general. Thank you for producing some PowerPoint slides that you didn't just read word for word. I thought the diagrams and the sort of infographics were all really, really helpful. Nice presentation lengths, and they're all very clear, so thanks for that. Secondly, I've remembered that SBAs are still one of the worst tests known to mankind, and they remain evil through not only the primary but also the final. There's always two answers you can narrow it down to. A lot of the time it's about trying to tease out what the examiner wanted instead of actually trying to answer the question. I appreciate that that is just difficult and there's no way around it. And thank you everyone for contributing and at least having a go. One of the things you have to do when you're doing exam practice is commit yourself to answers. Don't sit on the fence where you can, because it teaches you where your knowledge isn't great. You know, you're expecting to make one mistake in every multiple choice question. So, you know, by the time you're exam ready, you should be hoping to get sort of 4 out of 5 of each stem. And there are going to be stems where you get none and stems where you get 5, but hopefully there'll be far fewer of the ones where you get 0. That was a really good session. I hope it was useful. Anything you wanted to chip in, David, as you're clearly sitting there? You're muted, by the way.
Thank you very much for everyone that contributed. I'm sorry I was grossly late, but that's clinical life, I suppose. And thank you, Andy, for hosting as well. It's been much appreciated.
Okay, in that case, I'll conclude the meeting. So thank you very much. Do they have access to those presentations some way, somehow? Are they uploaded to the EMSA drive in some way?
The presentations will be on the EMSA drive. They'll also be on our, we have a meeting virtual teaching homepage, and there'll also be a video of this going up in the next couple of days as well.
All right. Thank you very much, everyone.
Thank you, guys. And if you could just fill in the feedback that I'll send via the WhatsApp. Last time we didn't get too many people replying to the feedback, so it is really helpful if we can get some feedback, especially since we've changed a few things from the first few sessions. But yeah, thanks for coming, and thank you, Dr. Ling.
No problem. All right, take care.